Okay. Good morning. Welcome to another Medicine Grand Round session via Zoom. Today we continue our discussions on COVID-19 with a focus on the cardiovascular impact. We are fortunate to be joined by two distinguished members of our cardiovascular division who will provide an overview of the pathogenesis and management of COVID-19 cardiovascular complications. As a reminder, please use the chat function to ask questions to our speakers. I'll relay them at the conclusion of both talks. So leading off today is Dr. Kory Lavine. He's currently an associate professor of medicine in the cardiovascular division. He completed his MD PhD training, IM residency, cardiology fellowship, and advanced heart failure and transplant fellowship here, all at WashU. He's been highly decorated since his undergraduate years, most notably winning awards in 2011 as the Rising Star Research Award for the Division of Cardiology. 2012, he was the Knowlton Incentive for Excellence Awards. 2015, he won the Career Award for Medical Scientists. And currently, his research interests are in understanding the immunological mechanisms that govern cardiac recovery and the pathogenesis of heart failure, as well as the pathogenesis of primary graft dysfunction in cardiac transplantation. Dr. Lavine will be discussing the pathogenesis and cardiovascular manifestations of SARS-CoV2 COVID-19. Immediately following will be a discussion on assessment and management of COVID-19 related cardiovascular complications by Dr. Joel Schilling. He is currently an associate professor of medicine in the immunology, pathology, and cardiovascular divisions. Dr. Schilling also completed his MD PhD training here with a focus on immunology before finishing his IM residency and fellowships in cardiology and advanced heart failure and cardiac transplant. Also no stranger to success, he has been recognized throughout his career with notable awards, including in 2003, he won the William Peck Book Award in Internal Medicine. That's awarded in recognition of the highest achievement in internal medicine. He also won the Knowlton Award for Clinical Excellence in 2007. In 2009, he won the Burton Sobel Award for Excellence in Cardiovascular Research. He holds clinical interest in heart failure and cardiac transplantation, currently runs the Schilling Lab, which focuses on the role of cytokine signaling in cardiac metabolism, with the aim to understand the role of inflammation in diabetic heart disease. Please welcome our speakers as they lead us through the cardiovascular manifestations of COVID-19.
Good morning, everyone. Adam, thank you for the introduction. Joel can give me a thumbs up if you can hear, to make sure I'm not unmuted. All right, sounds good. So as Adam mentioned, I'm going to talk about the pathogenesis and a little bit about the cardiovascular manifestations of SARS-CoV2 or COVID-19 infection. And then Joel's going to go deep into individual components of the cardiovascular syndrome and management issues. So the outline of the topics that I wanted to hit on were to review some of the salient points that Mike Diamond discussed in detail several weeks ago about SARS-CoV2 biology and viral pathogenesis as they relate to the cardiovascular. I'm going to give a general overview of the COVID-19 disease manifestations that involve the cardiovascular system. And again, Joel's going to go into detail about clinical elements and management. Then I'm going to talk about the potential mechanisms of disease pathogenesis, and then end by discussing investigational strategies to learn more, to truly understand mechanisms of pathogenesis and move forward with more elegant treatment strategies. And I'm going to highlight a human model of SARS-CoV2 myocarditis that my lab has begun developing in collaboration with Mike Diamond's group and Michael Greenberg's group as well. I have no relevant disclosures. I'm not going to discuss anything relevant to Medtronic or Amgen, but I will discuss some off-use of hydroxychloroquine, azithromycin, remdesivir, and tocilizumab. So as what was highlighted several weeks ago, SARS-CoV-2 is an enveloped single-strain positive RNA virus. It's a relatively large genome. Key elements of the virus is the spike protein, or the S protein, which interacts with the ACE2 receptor, which is how it enters cells. There's other proteins on the envelope, such as the E protein and the M protein. Their functions are incompletely understood, but there's emerging evidence from our institution as well as others that they can act as essential danger signals and activate the immune cells within the blood and within tissues as well. And then within the capsid is genomic RNA, which is the genome of the virus, and a nucleic capsid protein. The virus itself, it has a large genome. It's closely related to SARS-CoV or SARS-1, and as well as the MERS virus, as you can see in the figure below. There are some subtle differences between them. The biggest differences exist between the MERS virus and the two SARS viruses. The MERS virus actually enters cells through a separate mechanism than SARS-CoV-1 or SARS-CoV-2. The biggest protein that people talk about is the S protein, or the spike protein, which mediates cell entry, or is at least essential for cell entry. And there's about 76% amino acid identity, between these different viruses. SARS-CoV-2 is a beta coronavirus. As I mentioned, it's related to SARS and MERS. This is a nice dendrogram here showing just how related those two viruses really are to each other. Okay. We've learned, I think, just over the past several weeks that has been published that SARS-CoV-2 is probably of bat origin, despite many rumors and conspiracy theories. Like many pandemic viruses, it initially existed within an animal host and then jumped species. And so in this context, it existed within the bat and then jumped species to humans. And the amount of time that it's been within humans is not completely understood, but clearly is a possibility. Okay. Some interesting data has emerged over the past several weeks from Iceland. So Iceland has an interesting healthcare system, as everyone knows, where there's pretty much uniform access throughout the population. And they keep really elegant and detailed records of people's clinical manifestations, their demographics, as well as their genetics. And their government's tightly aligned with the deCODE consortium, which is a genetic consortium that really specializes in looking at genetic variability between individuals. And so the government of Iceland and deCODE has teamed up to essentially offer free testing to anyone who has symptoms of COVID disease, or anyone who just wants to be tested at all. And they're able to trace the genetics of the virus throughout their country. And as displayed in this dendrogram here, there's actually more than one strain of SARS-CoV-2. Different strains exist in different locations. Within these classifications, a given subtype, like the B1A subtype, you can see there's diversity amongst that particular strain of the virus. And so the deCODE consortium was able to look at the evolution of the virus over time. So they started March 2nd and genotyped viral sequences in patients who displayed symptoms of infection. And early on, they saw that there are largely two different strains, the A2A2 and A2A1 subtypes of the virus. And then over time, testing became more free. And the dashed line represents the time point where the deCODE registry was offering free testing to anyone who wanted it. And you can see during that time, there's an emergence of different substrains of SARS-CoV-2. So we don't know yet whether different substrains are related to different manifestations of infection, but I think that's a possibility that will clearly be fleshed out over the next several months, as well as host genetic interactions. So they're sequencing the individuals that were infected as well to try to understand, is there host variability that plays a role in disease susceptibility, and how does the viral genetics and host genetics interact? So more to come with that, but I think that's an interesting and emerging area that may be relevant to understanding why SARS-CoV-2 produces such a spectrum of disease. So mechanisms of cell entry. This is important when it comes to thinking about disease manifestations across any organ or tissue. So what we know is that cell binding and entry is dependent on the expression of ACE2. So the virus binds to ACE2, and that's a necessary step for the virus to initially enter a cell. The actual binding to ACE2 does not appear to directly affect the enzymatic activity of ACE2, which converts angiotensin 2 to which is a vasoconstrictive peptide, to angiotensin 1,7, which is a vasodilatory peptide that may also have some inflammatory roles. But there are some studies with the initial SARS virus suggesting that it may downregulate the cell surface expression of ACE2. The virus has to gain entry into the cytoplasm of the cell. So there's two ways it can do this. It can do this by directly going through the plasma membrane, and that requires a second enzyme called TMPRSS2, which cleaves the spike protein. Or it can do that through the endosome, where the spike protein is cleaved through a acidic sensitive enzyme like cathepsin L. And these acidic sensitive enzymes within the endosome are the targets of drugs like hydroxychloroquine, chloroquine, or a more novel compound, E64. And so we know the virus can get into the cell either way. We do not know yet which one of these mechanisms is more important. That may vary from tissue to tissue and cell type to cell type. We know that each of these viruses support lytic infection of epithelium, like lung epithelium or kidney epithelium, but they also can support other life cycles, such as abortive infection, where the virus gets into the cell and may transcribe genes, but does not necessarily replicate, and that could alter a cell's behavior or activity. So SARS-CoV2, anyone who's spent time in clinical element in the ICU, in the ER, or on our wards knows that there's a large spectrum of disease. We know now that a large number of patients are actually asymptomatic. 50% of patients who tested positive in Iceland displayed no symptoms at all at the time of testing, and some of which never displayed symptoms. And we know that asymptomatic transmission has been well documented across multiple countries. Common symptoms are fever, dry cough, and fatigue, flu-like symptoms that are seen in the community and in ambulatory setting. There's uncommon symptoms like the loss of smell, which we're screened for every morning, nausea, vomiting, sometimes chest pain, and even a encephalopathy. Severe disease manifestations are the things that we see more commonly in the hospital, things we're more concerned with, things like cyanosis, hemoptysis, persistent chest pain, high-grade fever, respiratory distress, kidney failure, leukopenia. SARS-CoV2 cardiovascular manifestations include myocardial injury. This is actually common severe disease. About a third of the patients in the ICU will have some element of a positive troponin or evidence of myocardial injury that seems to peak a little bit later after the onset of respiratory distress. Some patients will develop new onset LV systolic dysfunction, which is presumed to be myocarditis. Arrhythmias are common. Sometimes we'll see sinus bradycardia, junctional bradycardias, atrial fibrillation, ventricular tachycardia, and even cardiac arrest, which presents in this case as pulseless electrical activity. Myocardial infarction can happen. There's cases of in situ coronary thrombosis that have been reported in Italy and New York. Severe vasodilation is a very common manifestation where patients have profound vasoplegia, need high-dose pressors that seem to be a little bit out of proportion to their disease severity. Stroke has been increasingly reported. Peripheral thrombosis is something that I think we knew about initially in the ICU. First kind of noticed with hemodialysis lines clotting and patients requiring continuous infusions of heparin to get any type of dialysis. And now there's reports of arterial and venous thrombosis outside those mechanical circuits as well, and of course cardiac arrest. The risk factors for severe COVID infection seem to overlap nicely with cardiovascular manifestations. So patients who at risk are those who are older, for whatever reason male, have prior cardiovascular comorbidities. Leukopenia, specifically lymphopenia, is highly associated with severe disease and cardiovascular manifestations. Obviously, an elevated troponin, patients who have high AST and ALT at presentation, and then other laboratory abnormalities such as high IL-6 levels, D-dimers, ferritins, CRPs, and high LDHs. But the biggest risk factor is essentially age. Patients who are older clearly do worse, have a higher incidence of cardiovascular manifestations. But certainly there's cases, and everyone I think has had some experience who's been involved with these patients, seeing individuals in the 30 to 40-year-old range, or even the 18 to 25-year-old range, presenting with cardiovascular manifestations, including myocarditis. So here's an example of a case report that was in JAMA Cardiology of COVID-19 myopericarditis. So this patient had a troponin T of about 0.9, which is equivalent to a troponin I that's substantially higher, 5 to 10. An LV ejection fraction that was newly depressed at 35%, and their echoes showed apical predominant hypokinesis, or the walls at the apex of the heart were sluggish and hypokinetic. The EKG tends to show these lower voltages, as seen in the limb leads here, and minor ST elevations, as you can see in lead 2 and lead 3. And this is, I think, a very common EKG for a patient with myocarditis. This individual actually was stable enough to undergo a cardiac MRI, which is quite useful in thinking about the etiology of the positive troponin and the EKG changes. Of course, they had no coronary disease, and then this individual had increased stir signal, which is a measure of myocardial edema in the apical anterolateral walls, and that was confirmed on T2 mapping, shown here, as well as a large pericardial, or I should say moderate-sized pericardial effusion around the heart. This is kind of a classic example of myopericarditis. Other cardiovascular manifestations that we see involve the vasculature. And these can be anywhere from stroke, pulmonary emboli, to elements that look a little bit like a vasculitis. And so this is a published report of a patient who developed a splotchy lesions on their extremities. So here's their toe. This is another patient who had lesions on their arm. This individual, as you can see, underwent a skin biopsy, and that skin biopsy showed fibrin within the vasculature, so fibrin clot forming, and deposition of complement throughout the vasculature, both C4D as well as components of the C5 complex. And they were actually able to stain for some viral elements, and in red is the spike protein of the virus, in green is C4D, a complement split product. You can see within the vascular endothelial cells, you see co-localization of both complement with viral spike protein expression. And so this may be related to viral infection of endothelial cells, activation of complement, and potentially microvascular thrombosis as a proposed mechanism. And this is the proposed mechanism of the what's been reported in the lay news as COVID toes. Other hypercoagulable conditions in general are clearly present. One study looked at thromboelastograms, or TEGs, and they were able to show clot formation time was substantially shorter, and high maximal clot firmness was present in multiple types of stimulations and ways of looking at that assay. So clearly there's derangements in coagulation and thrombosis that may contribute to some of these cardiovascular disease manifestations. The time course where we see these, patients initially present with fevers, myalgias, cough. They develop rapidly progressive hypoxic respiratory failure. This is an example of a CT scan showing diffuse alveolar pulmonary infiltrates, classic for ARDS. At that time, seeing acute kidney injury and failure with the need for dialysis is common. And about that time in the disease is when hemodynamic instability and cardiovascular complications manifest. Other individuals have looked at biomarker profiles and viral RNA copy load across the time, this time course of infection, to try to give some pathophysiologic idea of what may be driving these disease manifestations. And as you can see in the top figure, This is looking at viral RNA copies. And so the y-axis is CT value. The lower the CT value or higher in the axis, the more virus. The higher the CT value, bottom of the axis is less virus. And on the x-axis is the day since onset of symptoms. You can see that the virus is higher early on and then falls over time. At about the 2-week time point, most patients have undetectable or barely detectable viral RNA copies within the blood. As a side note, that doesn't mean that these viral elements not in the blood, but in the respiratory epithelium this doesn't mean that these viral elements are necessarily infectious. It just means that we can detect the viral RNA. If you use that same time course and you look at other biomarkers that may be involved in inflammation, such as CRP, D-dimer, ferritin, IL-6, and correlate those to troponin and others, you can see that for patients who do well, there's an initial peak of inflammation that appears to occur a little bit before 2 weeks, and that goes down. And for patients that do poorly, the inflammation is high at baseline and then continues on up. And this is probably best denoted for both LDH and CRP. CRP values can be exceedingly high, anywhere from 150 to 400, which is quite substantial. And so based on this information, it's been proposed that some of the manifestations of COVID-19 may be due to productive viral infection by the virus to target tissues, and then subsequent manifestations may be due to over-exuberant or other derangements in the host inflammatory response. This is a hypothesis at present, and that's been put forth, and we really have little information to say it's one or the other. However, based on these models, a number of clinical trials have been designed. So most trials are focused on viral activity. Drugs are initiated up front, and trials such as tocilizumab that look at inflammation, those drugs tend to be started a little bit later when theoretically the virus is at a lower load. So in thinking a little bit more about how these disease manifestations occur pathophysiologically, it makes sense to look at where the virus is and where the virus infects. And so we know that both SARS viruses affect the lung epithelium. This is an example of an immunostaining image for the spike protein, showing the spike protein both in leukocytes as well as in respiratory epithelial cells. This is an electron microscopy image showing the virus within respiratory epithelium. It's a classic crown-like structure with little spikes on the end. But it also infects other tissues. We know it infects kidney epithelium, intestinal epithelium, and I'll show some data that it may infect the myocardium and vasculature as well. I think we showed the vascular data from biopsy already. So this is the only case report of endomyocardial biopsy in a patient with suspected SARS-CoV2 myocarditis. This individual needed to go on ECMO and subsequently recovered after 6 days of mechanical support. And within this biopsy, you could see viral elements within the myocardium. It wasn't clear what types of cells were infected from their studies. We don't know whether this represented a degenerated cardiomyocyte or another cell type within the heart, such as an immune cell. But clearly it was within the organ itself. And to truly understand these relationships, we need experimental models to parse effects of direct viral infection and the effects of the host inflammatory response. And so our classic strategies are to take mice, infect them with virus, and understand what occurs and use all of our genetic tools that we're comfortable working with to delineate mechanisms. But unfortunately with this virus, if you infect a normal laboratory mouse, you get a healthy mouse, and essentially nothing is seen. And there's a number of reasons that likely underlie this, but one of the probably most prominent reasons is that the mouse ACE2 receptor is different than the human ACE2 viral receptor, both at sequence and amino acid levels. And so there's a number of animal models being constructed that overexpress the human ACE2 within the mouse within specific tissues, or just replacing the mouse ACE2 with a human ACE2 protein, and those models are just becoming available now. So a number of laboratories, including our own, have looked at alternative strategies that we may be less comfortable with, but could be very useful for studying these sort of pathogens. And this is using human organoids or engineered tissues. Usually what occurs in these sort of settings is you use human pluripotent stem cells, iPS cells or ES cells, derive specific cell types of interest, and then assemble these into a tissue to create an environment that mirrors what's seen in the body. And so this can be done across a range of tissues. People can make vascular tissue with arteries and veins. They're complete with endothelial cells, pericytes, fibroblasts, and smooth muscle cells. This can be done with the kidney. This technology really didn't exist much at WashU until Ben Humphreys came several years ago now, and he's really adept at making kidney organoids for study of both development as well as disease pathogenesis. And these organoids can be used in an experimental tractable way to study how the virus infects cells and elicit immune responses. So this is an example of a kidney organoid which was infected with 2 doses of virus, and they were clearly able to see evidence of viral replication based on a plaque acid. So we've taken a similar approach using human engineered heart tissues to try to understand key elements of how this virus affects the heart. These organoids can be made in 2 dimensions, which means made in a monolayer on a tissue culture dish, which is nice for high throughput experiments. We also can make tissue elements. This is an example of a 3D tissue where it's essentially a ring. We kind of joke around and call it a calamari ring. Or we can make tissue strips as well in different sizes and actually expose those to force and tension as the heart is normally exposed to. You can assemble these tissues from anything you want. So for instance, cardiomyocytes, you can make tissues from the heart that contain cardiomyocytes, fibroblasts, and we mix and match different types of immune cells. You can put endothelial cells into the mix, and then you can separately change the genetics of each of these cell types. So you can remove or overexpress specific genes to probe mechanism, which makes this model experimental. And so this is an example of our system. This in white are cardiomyocytes, and green are a monocyte-derived macrophage, which we think are involved in inflammatory responses in the heart. And in blue are that aren't stained with either of the other markers are fibroblasts. And you can see how the cells are arranged and interact with each other. We can use this to study how the virus enters cells. We can use this to see how cells get activated. But we also can use the system to look at elements like contractility. So I'm going to take my laser pointer off for a second and play this, and you can see that these tissues actually contract, and you can measure key elements of diastolic as well as systolic function. And this is an example of the system where we're looking with Michael Greenberg's lab, who developed this, to examine control tissues and tissues that contain cardiomyocytes that harbor a dilated cardiomyopathy of mutation. If you look at the amount of force generated, it's clearly decreased across conditions. So we repurposed this system to look at COVID myocarditis to see if the SARS-CoV2 virus could infect our tissues. And so these are the experiments that have been done to give you an idea of where we are in this project and where we'd like to go. So on this side of the screen is viral RNA copies using an RT-PCR assay similar to what's used clinically with nasal swabs. And on the right are focus forming units, which is a measure of whether whether virus replication has occurred and whether viruses that are in the tissue culture supernatant can infect another cell. So we produce productive viruses. And so we use the system to understand what cell actually gets infected within our tissues. And so we had several conditions, just cardiomyocytes, just fibroblasts, just macrophages, or different combinations. And as you can easily see from these plots, that cardiomyocytes are the cells that get infected. With this focus forming assay, you only see infection in cardiomyocytes, highest at day 3 and decreases at day 6. And then we can see similar amounts of productive virus generated from cultures that contain combinations of cells, but they had to have cardiomyocytes within them. And importantly, if we use an ACE2 antibody that neutralizes the binding of the spike protein to the ACE2 receptor, we can decrease the number of viral elements generated, suggesting that the ACE2 receptor may be important for the virus to enter cardiomyocytes. We can do this in 3D tissues as well. This is an uninfected tissue. These are two infected tissues. We're staining for the spike protein, or in this case, the spike RNA. And we can either use a sense probe, which looks at the genomic strand, or the anti-sense probe, which looks at transcription. And you can see that there's clearly evidence of the virus within these tissues. We can look by electron microscopy and see the virus as well. So this is a cardiomyocyte within one of our 3D cultures or tissues. And these are different zoom in pictures. This particular cardiomyocyte, you can see a SARS-CoV2 virus here. You can see a recycling endosome that may be full of virus. And we could see evidence of viruses budding or virions budding off the cell membrane, which is highly suggestive of infection. The other thing we can do with the system is to try to understand how the immune system gets activated and whether that is a beneficial or deleterious mechanism within the system. Obviously, different effector molecules may have different functions, and we'd be able to parse that and think about anti-inflammatory therapies if that was a driving force for COVID myocarditis. And this is RT-PCR for two genes that report type 1 interferon activation, MX and OAS over here. If you just infect cardiomyocytes with the virus, you can see a small increase. You see little increase across other conditions. But if these cultures contain macrophages in an infected cardiomyocyte, you see robust activation, which is suggestive that macrophages within these cultures are responding to infected cardiomyocytes and activating type 1 interferon signaling. We can see a myocarditis pattern on histology. There's H&E stains that you typically do with pathology on our tissues. This is the uninfected and infected in a culture that just contains cardiomyocytes and fibroblasts, and it's hard to tell the difference. But when you add macrophages to the mix, you can see that these cells accumulate and tend to be focused around sites of myocardial injury. And that's really best seen using immunostaining here, where the macrophages are stained in red, a particular subset of inflammatory ones, as well as dendritic cells, are in green. And you can see that these cells form clusters, likely form clusters around injured or dying cardiomyocytes as shown. And so we're very interested in using the system to understand how the virus enters the cell, how it enters the cardiomyocyte. How could that be drugged? How does it replicate in a cardiomyocyte? How does it spread from one cardiomyocyte to another? And how does it activate the immune cells that are resident or recruited within the heart? And can we use any of those elements to try to improve viral clearance or reduce deleterious effects of immune cell overactivation? And so we're working now on using the system to address those questions, as well as to test the many compounds that have been moved to the clinic with fairly little preclinical data to understand whether they may be effective within the heart. We now know that remdesivir may have some potential benefits. I guess that's rumored on briefings. We'll wait for the data to fully be reported to evaluate that. But there's many other strategies being proposed, such as IL-6 blockade, which is currently under clinical trials, as well as a number of designer neutralizing antibodies, some developed here, some developed outside, as well as macromolecular protein traps that harbor either enzymatically active or inactive ACE2 to act as a sponge for the virus. And having a tractable system to study these is really important. And so with that, I'd like to thank my group for the people that did the work. Those are underlined here: Andrea Bredemeyer, Andrew Koenig, Pan Ma, Ben Kopecki, and Sasha Dementrico in my lab. Mike Diamond's lab has been really paramount to these studies, an excellent collaborator. Adam Bailey really has been driving this project within his group and has done a lot of the work that I showed you related to infecting these cultures and measuring the virus. Michael and Lena Greenberg are instrumental for developing the engineered heart tissue system and are imaging specialists at the WashU Center for Cellular Imaging, led by James Fitzpatrick. So thank you very much. I'm going to heed to Joel, who's going to talk a lot more about clinical manifestations and how we're approaching to treat those. So Joel.
All right, great. Kory, can you see that? Okay. So again, thank you to Adam, and thanks to Kory for a really wonderful discussion about some of the basic biology surrounding our understanding of COVID-19. And as he alluded to, I'm going to try to delve a bit more into some of the components that are more clinically focused about assessment and management of many of the COVID-associated cardiovascular complications. I have no relevant disclosures for this particular talk. So again, I just want to start with a brief case that illustrates some of the potential manifestations one can see. This was a gentleman from New York, a 38-year-old, type 2 diabetes, came in with shortness of breath and cough, tested positive for the SARS-CoV2 virus, had a rapid decline in respiratory status. This is often seen with hypoxemia, worsening respiratory acidosis despite advanced ventilatory strategies. Ultimately got placed on VV ECMO. However, in this setting, developed persistent hypotension and elevated lactate. Initial EKG demonstrated lower voltages in the EKG, some nonspecific T-wave changes, which ultimately progressed to a IVCD, or interventricular conduction, interventricular rhythm. This was in the setting of having high markers of inflammation, as Kory alluded to, a CRP of 300, a high sensitivity troponin that was elevated. At that point, an echo was performed, revealing an ejection fraction that was depressed in a de novo fashion, and this patient was converted from VV ECMO to VAV ECMO and successfully decannulated at 7 days after these events. So it kind of sets the stage of how severe cardiovascular manifestations can present. So with the remaining 20 minutes or so, I'd like to focus a bit on some more of the granular data regarding prevalence and prognosis associated with cardiovascular disease complications in COVID-19, and then how you should really assess and some of the new ways we have to think about assessment of cardiovascular complications in the setting of this syndrome, and then to cover the management strategies for cardiovascular disease, which in reality are just kind of a professional opinion approach. So as Kory alluded to, this is a figure that came from a recent article in JHLT. We tend to think of this virus as having an earlier phase associated with significant viral replication, which then can progress to some of the respiratory failure phase, and then a later stage that in some individuals becomes a hyperinflammatory response, where we often see more of the severe complications. And this tends to be the area of disease where we see many of the cardiovascular manifestations. So Kory alluded to some of these things. So what are some of the manifestations that we see? And we're still learning a lot about this. Most data surrounds the use of biomarkers to detect myocardial injury. You can see cases of acute coronary syndrome. More of these case reports are showing up, and it's similar to what's been reported with other severe viral infections like influenza. You absolutely can see cardiac arrhythmias that become higher in prevalence the sicker you are. And then you can see evidence of cardiomyopathy and true components of cardiogenic or mixed shock, which can occur anywhere in 20 to 30% of critically ill patients, and per estimation accounting for somewhere between 7 and 30% of COVID-19 related deaths. Now, again, whether these mechanisms are myocarditis, cardiac dysfunction from systemic inflammatory responses, or perhaps some of the microvascular thrombotic events that can occur, I think is still a matter of debate. And then it's very clear that all of these things are amplified in individuals who have pre-existing cardiovascular disease. So let's look at some of the data that really surrounds the statements that have been made about biomarkers being useful. So this was one of the earlier reports that came from a case series in Washington. It was only 21 patients that had severe COVID-19 disease, 2/3 with overt ARDS. And the vast majority of these had at least one comorbidity related to hypertension, diabetes, asthma, kidney disease, or prior stroke. And really one of the, one of the features that came from this study was the incidence of cardiomyopathy, which was reported in this study at close to 30%. And really this was defined as individuals who had de novo globally decreased LV ejection fraction on echo. And in addition, they had to have some other clinical manifestation of cardiogenic shock, be that an elevation in biomarkers, decrease in SpVO2s, and again, they could not have a prior history. So it suggested that the heart could be involved in a significant number of patients with severe COVID-19. Now, in larger patient series that have come out of China, we have a greater understanding of at least using these markers as sort of a risk predicting tool. So if one looks at this initial study here involving almost 460 patients, this is from Wuhan, China, looking at individuals who had a positive troponin T versus those without evidence of positive troponin T. Really the striking feature is that, those, shown here in the orange line with cardiac injury had a markedly increased mortality of nearly 50% by 3 weeks out compared to those without cardiac injury. And the vast majority of these individuals who had cardiac injury did have some cardiovascular comorbidities. Another fairly interesting study that also came out of Wuhan was dividing patients into those who had the combination of prior cardiovascular disease and an elevated troponin, shown here, had the highest mortality, nearly 70%, whereas those who had elevated troponin without prior cardiovascular disease had the second worst survival, with still nearly a 40% mortality. And those, even if you had prior cardiovascular disease but had no elevation in cardiac biomarkers, overall survival was much closer to 90%. Also noted in the study, individuals who had elevated troponin did have an increase in other cardiovascular complications such as ventricular arrhythmias. Now I'll just show you sort of one last study that came from the early Chinese experience. And this is one in which patients were divided into survivors and non-survivors. And in this, we see that cardiac troponin shows a significant signal for being increased in the non-survivors, but also we see markers of inflammation like CRP and IL-6 tracked with this. Now within this study, the authors also attempted to take the patients who had died from COVID-19 and tried to break apart what their cause of death was. In this subset, about half the patients died of predominantly respiratory failure and hypoxemia that could not be addressed. However, there was another third of these patients who were reportedly died of combinations of respiratory and circular failure, and then almost 10% that were reported to have a predominant circulatory or cardiovascular basis of their death. Now, in fairness, they don't really go into details of how they adjudicated these mechanisms of death, but I think it suggests that understanding the circulatory involvement related to COVID-19 may be particularly important in severe disease. So I stole this from a recent review from Journal of Cardiac Failure, which kind of deals with what does troponin actually mean in the context of this scenario. And I think there are many possibilities that can lead to cardiac injury in the setting of a severe inflammatory COVID-19. Of course, cytokine involvement, something similar to what we see in sepsis, where high levels of inflammatory cytokine can directly impact the cardiovascular cells and macrophages in the tissue that can promote local injury. Likewise, you can have the microangiopathy and thrombosis, as we discussed. You certainly can have evidence of myocarditis. As Kory alluded to, we don't know what percentage of patients truly have viral infection with severe inflammatory response to that, but I think it's an interesting area that needs further exploration. And then, of course, you can have true myocardial infarction from plaque rupture, or just from supply-demand mismatch in the setting of people with underlying coronary disease who are under duress. So really what I would say based on the summary of this epidemiologic data is that we can state that cardiac involvement, at least via biomarker assessment, is common in severe COVID-19, with a prevalence of close to a third of patients in severe disease, and really up to 50% of patients who ultimately die from COVID-19. Certainly those with underlying cardiovascular disease and diabetes are more likely to have elevated troponin, as well as they are more likely to die. And cardiac involvement is also strongly associated with the severity of respiratory failure and inflammation. We really don't see isolated cardiovascular involvement. And I think that's instructive when thinking about the pathogenesis of this disease. Okay, so if we believe cardiovascular disease is important, how should we think about and diagnose and assess cardiovascular disease in patients who present with COVID-19 disease? And I'll argue at the beginning of this that the calculus really changes a lot because of the nature of this infection. But obviously we have, as mentioned above, we have blood tests that can help us risk stratify patients, both based on cardiac injury as well as general inflammation. And then I'll delve a bit more into detail about things we can do with EKG to evaluate for ischemia, evidence of pericarditis, myocarditis, arrhythmias, what role may be there for echo, and then what about invasive assessments for patients for their hemodynamics, for looking at tissue, for looking at their coronary arteries. But I think one thing that is really, really important when we consider which diagnostic tests we might want to perform in these patients is we have to carefully balance the benefit of the test. Is it going to really impact management right now and change what we do versus the risk of exposure? Because many of these evaluations will expose healthcare workers to patients with COVID-19. And so this balance is very different than in the pre-COVID-19 era when we thought about using many of these diagnostic tests. Okay, so what about EKG? Kory touched on some of these things. We can see variable EKG findings in the setting of COVID-19. You can see ST elevations as shown here, which sometimes needs to be distinguished between true coronary thrombosis versus a myocarditis. We can see a lot of non-specific ST changes in T-wave inversions that have been reported frequently. Low voltages, which often are associated with myocardial edema or injury, definitely can be seen. But you want to try to assess clearly for evidence of ischemic changes, and then you can gain some insight into arrhythmias when they appear. So the EKG still can be a very useful triage-based test to direct other thoughts regarding management and other diagnostic testing. And what about echo? As a heart failure specialist, we love our echo. They provide a lot of information, certainly in folks who have acute inflammatory-related myocardial injury. We tend to find things like reduced biventricular function. Generally, we see normal LV size with increased wall thickness, especially with the acuity of this and myocardial edema. But sometimes you could use this testing to look for wall motion abnormalities that might point you to thinking about ischemia, although we recognize that you can also see this with some forms of myocarditis. But again, the real issue when thinking about echoes, as tempting as it is to order it in all patients with elevated troponin, is that we have to be careful about the exposure of sonographers to patients with COVID-19. So I think this really puts the onus on us to make sure that we're really directing these tests to people where it will make a difference and using their biomarkers, EKG, and then how are they behaving hemodynamically? Are we struggling with their hemodynamics to manage them and they're having persistent hypotension? This should be directed to help us identify patients who might really benefit from an echo. And then when you do the echo, you really should try to do a focused exam. Talk to the sonographer up front, really get only the necessary information that you need to minimize the amount of time of exposing that patient. And then now we're beginning to use things like point of care ultrasound, so handheld ultrasound devices that can be used by the provider who's already in the room to at least help identify individuals where there appears to be cardiac pathology and who might warrant further imaging. Now, although Kory did show some images of cardiac MRI, and certainly from a research standpoint, this would be very, very useful to understand what's happening in the myocardium. As a general practice, we're not recommending routine use of TEE or MRI, given the potential risk of exposure and moving patients out of the unit, et cetera, in the setting of this, but we'll see how this evolves over time. Now, what about invasive hemodynamics? So those of you who have ever worked with me know that I love cardiovascular hemodynamics. I spent a lot of time doing this in the cath lab. What I will say in this scenario, however, is little is really known about the overall hemodynamics of COVID. As Kory mentioned, plegia is very common, so more of a Sears response. However, some can have a mixed picture involving both an inflammatory vasodilation and cardiovascular components. And then in particular, individuals who have underlying cardiovascular disease, these mixed shock patients can be particularly hard to manage without really identifying what's going on from a circulatory standpoint and a filling pressure perspective. So perhaps this is a spot where we could consider the use of this. However, in general, I would say through the use of A-lines, SCVO2 monitoring, and CVP assessments, plus or minus echoes, these may be should probably be a more routine practice for assessing hemodynamics. So as much as I hate to say it, I would argue that the role of routine invasive assessment should be limited to those in which we really think it's necessary to manage them. So what about coronary angiography in COVID-19? This has led to a whole lot of controversial discussions throughout the cardiovascular community. So I'm going to summarize a big controversial area with some general points. So I think in general, we'd agree that non-STEMIs in most cases should receive conservative medical therapy, even if we think it's related to coronary related events instead of just a type 2 MI. Unless the patient is developing worsening cardiovascular function, worsening hemodynamics, in which case this could be discussed. The bigger challenge is in the setting of STEMI, which in first you have to recognize, is it really STEMI or is this perhaps myocarditis? And given the delays that may be necessary to safely activate the cath lab, this can have an impact on door to balloon time. So the idea of trying to use high and low risk features based on their clinical assessment and EKG findings, as well as using echo more frequently to really look for wall motion abnormalities to convince yourself this is truly a STEMI. All of this has led to a rediscussion of the use of lytics in scenarios where increased delays may happen in getting patients to primary PCI. So this is, even in our center, has led to a lower threshold for the discussion of lytic therapy. However, I will state that still primary PCI is preferred when this can be performed in a timely fashion. But it's really, really important that we work to avoid contamination of cath lab facilities, and really staff protection is paramount in this algorithm. So this is a brand new algorithm proposed from the ACC that was recently published, and looking at individuals who have ST elevation on the echo or on the EKG where you think they have COVID, or COVID is more of just a possible, where you need to look at, of course, their symptoms. Is this really consistent with MI? Does the EKG suggest this? You still might want to consider the use of POCUS or an echo to really confirm this looks like a STEMI. And if this is the case, then you have the ability then progressing towards primary PCI, generally speaking, is the best option. If it's really unclear, you may need to consider other etiologies, and this can be a trickier decision that involves sort of multiple team members to decide whether going to the cath lab is worth the risk. What about NMR cardio biopsy? Again, this is a procedure we perform regularly in our transplant patients and occasionally in other forms of myocarditis. At this stage, of course, there's really no proven utility, and we have very few myocardial biopsy samples that have been performed in these patients. There is some question about these findings. Of course, if you looked at the degree of immune involvement versus viral RNA, you could get some idea about whether anti-inflammatory versus antiviral therapies may be more effective in a given patient. In point of practice, it can be performed at bedside, and we often will do these in certain cases at bedside in the CT ICU in patients on ECMO with echo guidance, but it does, of course, expose individuals, again, to an infected patient. So at this stage, I'd say that routine use of NMR cardio biopsy really is not warranted. However, if built into other components of clinical trial management for anti-inflammatories and antivirals, this could be reasonable. At this point, I think we'll have to rely more on autopsy cardiovascular samples to see what's going on. Just as a interesting side point, that in SARS-CoV-1, viral RNA could be found at autopsy in about 35% or so of cases. So I think that the viral involvement of the heart may be very significant. One other point that I just want to touch upon as we're kind of transitioning here from assessment to management is this question that has come up frequently with regards to these patients and their chronic cardiovascular meds. And this is particularly surround the ACE inhibitor and ARB medications, where early on there were concerns that through effects on ACE2, this may actually worsen clinical situations. Then there was some evidence that maybe it would be protective in the lungs. So we now have at least some increasing retrospective data in this, and I just want to point this out. So there were 2 studies that came out of China, recently published in JAMA Cardiology and Circ Research. So in Wuhan, there was nearly 1,200 patients. About a third of them had hypertension. In the hypertensive group, about a third were on an ACE or an ARB. The overall mortality in the hypertension group was 21%, and they saw no signal for any differences based on those who were taking ARBs and ACE inhibitors and those who were not. And then there was another multi-center China experience that had nearly 1,200 patients, all of whom had hypertension, with nearly 200 that were on ACEs or ARBs. And in this study, they actually used propensity-based analysis to suggest a survival improvement with ACE and ARB therapy, which is shown over here in the panel. And this was a recent study from Circ Research. So with the limitations of propensity analysis, I think we can at least feel confident saying that these drugs are relatively safe and probably should at least be continued in scenarios where there aren't other complications due to hypotension or renal failure. Okay, I'm not going to go through this in detail. This is something I stole from a recent publication that we put out at the ACC COVID Hub. Just some clinical pearls of how you can begin to think about the management of these patients. So in the interest of time, I'll mainly refer you to kind of look at this if you have an interest on the website, but it kind of touches on many of these points of how to use biomarkers and imaging in individuals who you suspect cardiovascular involvement. So with the remainder of the time that we have here, I want to focus a bit more on management, and I will definitely say that this is certainly an area of professional opinion rather than absolute consensus. And these really represent guidelines only, not a substitute for clinical judgment. So in general, when we think about the management of COVID-19, we have the supportive care. I touched a bit on the chronic cardiovascular meds, but we're mainly going to talk about things like how do you manage their hemodynamics and their fluid balance and their prothrombotic state, and what is the potential role for other forms of support, such as ECMO. And then the disease targeted, which I won't spend much time talking on, that would actually directly target the virus or the inflammatory response. So when we think about the supportive, I think in general, we're employing similar goals to what one would use for other forms of SEERS and mixed shock pictures. So in general, you do want to avoid over-aggressive fluid resuscitation for hypertension, as this can certainly worsen hypoxemia, and if the patient has cardiovascular involvement, could exacerbate that further. You want to target an adequate mean arterial pressure, somewhere in the ballpark of 60 to 65. In the majority of patients, first-line agent of norepi is probably most appropriate given the likely vasoconstrictive or vasodilatory component of the disease. However, individuals with significant LV dysfunction or persistent hypotension in the setting of this with positive biomarkers, considering the addition of inotropic support is reasonable. Epinephrine and vasopressin absolutely can be used in many of these patients, especially those with more refractory shock. And there have even been a few reports of using angiotensin II for refractory vasoplegia. Traditional hemodynamic goals in general are reasonable here. So CVPs that are at least adequate for cardiac filling, such as 6 to 8. However, this may need to be higher if you're using higher PEEP settings. And then you got to monitor and make sure that the patient's actually well supported, which can be done via assessment of lactates, SCVO2s, etc. So what about the management of the procoagulant state? So as Kory mentioned, we're beginning to see more and more of these thrombotic events that can occur. It's very clear that COVID-19 is associated with a procoagulant state. The mechanism of this is not well understood yet, but is likely multifactorial from the inflammatory response as well as viral-mediated infection and endothelial injury. The bottom line is that we certainly see that throughout the spectrum of cardiovascular disease, as illustrated over here on the right-hand side, that there is an increased risk for the formation of clot, both venous and arterial. There is some evidence that those with markedly elevated D-dimers are at particularly high risk of this. And so far, we've seen many manifestations, which can include microvascular ischemia in the heart and as well as the peripheral extremity, DVTs and PEs, myocardial infarctions, as well as strokes, which now are being reported in patients with less severe disease. Overall, there's been no clear consensus on anticoagulant therapy. However, I think, and as is the practice here, it's very reasonable in the absence of contraindications to use therapeutic heparin in individuals with severe COVID-19, particularly those with high D-dimers. But at all stages of disease, very low thresholds for use of DVT prophylaxis. These patients clearly are prothrombotic. And at this point, and this very long consensus statement, which basically says we don't quite know how to manage this, but certainly have a low threshold for using anticoagulants. What about the arrhythmias that are associated with COVID-19? Kory mentioned you can see a wide variety of these. The prevalence is close to half in patients who are very ill. A significant percentage of these are actually ventricular arrhythmias as well. And although we don't know everything about this particular infection, we have learned a lot about ventricular arrhythmias in the setting of myocarditis and cardiac inflammation from other etiologies. And in general, we'd say they can be related from acute involvement of myocardial inflammation with inflammatory cytokine signaling, edema, and myocyte injury. Or this also can be related to inflammatory activation of reentrant circuits in individuals who have prior scar, be that from a prior episode of myocarditis or prior MI. One thing that I'll say, in a recent study that came out looking at myocarditis in general, so not specifically COVID, there are certain features you can see about the ventricular arrhythmias that might be more suggestive of active myocarditis versus somebody with prior scar who's developing ventricular arrhythmias. And really the key features can be when you look at the ventricular arrhythmias, even your VT will tend to be irregular in individuals with active myocarditis related to some of the issues of acute cardiac injury and edema. You also can see that very polymorphic ventricular complexes also are associated with this and can really help you identify individuals that might have more of a acute myocardial involvement versus those who might have developed a reentrant circuit, which tends to be monomorphic and regular. As far as management, we really have nothing new to add besides what we recommended almost all patients who have ventricular arrhythmias in shock states, that you want to certainly optimize the easy things, their electrolytes, pay close attention to what inotropes and pressors are on and what they really need. Antiarrhythmic drugs, I think generally a preference for amio and lidocaine in this scenario, some degree of caution with beta blockers because of the potential respiratory effects as well as the negative inotropic effects. If you're going to use one, probably esmolol, short-acting IV agent is best. And then now we have, of course, this concern about hydroxychloroquine, which early on was getting a lot of praise as being a potential therapeutic here, but absolutely can prolong QT. And there's now even some recent data from a Nature Medicine paper looking at individuals as they're started on hydroxychloroquine. You can see that on average their QT interval continues to prolong out through the first 5 days of therapy. And if you look, as you break patients down, up to 10% of these patients will end up with a QTc excess of 500. So you have to be careful with these agents. You could definitely promote arrhythmias, especially in those with already elevated QT or underlying cardiovascular disease. So briefly, I'll touch upon ECMO in the setting of COVID-19. I think, in general, we have to think about this as a really scarce resource in this disease. It should not be routinely used. There's a few things you need to consider anytime you're looking at whether ECMO is appropriate. Like A, are you using it mainly for respiratory support, for circulatory support, or both, as this will dictate whether you use a VV or VA circuit. And then the real and the more challenging ethical question is really what patients should be put on ECMO. And you have to really look at the patient's underlying complications, their underlying comorbidities, what is their age, do they have irreversible chronic disease, how long have they already been sick, how long have they been on the ventilator, what other organs have been affected, i.e. what is the chance that the outcome of this is going to be favorable, because you are going to use up these components pretty quickly, and then they won't be available for people coming in with other issues requiring ECMO. So it has to be a careful decision to employ this. Without getting into details, the general configurations are all going to be peripheral. So for VV, largely involving the right internal jugular vein, and for VA, we're typically going to use the femoral for the arterial flow back into the circulation, and then the venous can be from the femoral or IJ approach. If you do VA, be careful about looking for poor cardiac ejection and the development of pulmonary edema. Now, last time I gave this talk, we didn't have any data about ECMO. Now we have just a little bit, so I'll briefly share it with you. There's a Chinese experience from Shanghai, total of 8 patients put on ECMO, 7 were on VV, 1 on VA. To the time point that they had observed so far, 50% of the patients had died. 3 were successfully weaned from ECMO with a duration of 22 to 47 days of ECMO support, but they were all still on the vent, and 1 remained on both ECMO and the vent. So not necessarily shows you you're in for the long haul when you go down this approach. There's now another study for multi-institutional study from the United States, looking at 32 patients from 9 hospitals just over a 3-week period. Again, the majority of patients on VV ECMO, but a subset on VA as well. The mortality to this point is 32%, ongoing ECMO in 50%. There have been 5 that have been weaned from both ECMO and mechanical ventilation, and even 1 hospital discharge. So you can have a successful outcome, but I think this illustrates the fact that, again, a lot of these patients aren't going to do well, and you have to be very careful about who you put on ECMO. I'm not going to spend much time on CPR. The most important point to make here is that whenever performing CPR on these patients, protection of the staff is paramount. The prognosis in these patients generally when they're resting is very, very poor, and therefore having 6 patients or 6 staff get infected during the last moments of someone's life is not a very favorable outcome in general. So protection is paramount. Trying to avoid a lot of bag mask ventilation or BiPAP is also a good idea. So again, just to conclude, when we think about this disease in terms of its phases and where to target things specifically against the virus or the host, Kory mentioned there's some new exciting data from remdesivir very early. We haven't seen the actual report, but a quick look suggests that this drug may actually have some impact on the viral part of this. There's a lot of interest in the host inflammatory part. Kory mentioned some of these. Corticosteroids early have been discouraged, but perhaps later in the disease may be beneficial. IVIG, tocilizumab, and even some discussion about IL-1 blockade has been considered, and really trying to target these when the infection is mainly at an inflammatory, hyperinflammatory phase, but before patients have really developed multisystem organ failure. And so again, ongoing studies are occurring in these areas, and that will direct where we go. So really to summarize where we're at, and we have a lot more to learn, and this will be a rapidly evolving space, but we can certainly say that cardiovascular involvement is common in severe COVID-19. Those who have cardiovascular complications absolutely have a worse prognosis, particularly if you have underlying cardiovascular disease. The risks and benefits of cardiac diagnostic testing have to be weighed very carefully, and it's a very different calculus than in the non-COVID era. Supportive care really remains the mainstay of management, but we really need to stay tuned for a lot of new exciting data on targeted therapeutics against the virus and the host response. And then one other area that really hasn't been discussed much, but I think is going to be a growing area of interest and research, is to understand what are some of the long-term cardiovascular consequences of COVID-19 in patients who have survived. And I think, again, we'll gain a lot of insight to this over the next several months. So with that, I'll give a shameless plug that if you're interested in some of these areas and want to read a little more about some of these points, we recently published an article on the ACC COVID-19 Hub. You just go to ACC COVID-19 Hub, and this article will pull up to look at management of the hospitalized patient. A couple of former WashU alum from the fellowship program, at least, were also a part of this. And with that, I will conclude. I'll go ahead and throw up your QR codes, and I'll be happy to take any questions, and thanks for tuning in.
All right, thank you so much, Dr. Lavine, Dr. Schilling, for 2 excellent talks. In the interest of time, we'll do 1 or 2 questions here since we're a little bit after 9, but I guess the first one would be for Dr. Lavine, and that would be, can you speculate whether differences in strains can account for the difference in manifestations in different regions/countries?
I'll speculate, maybe. I think over time, we'll see associations come out that may connect one strain in one region with particular manifestations and another strain in a different region, which is more likely to cause another manifestation. But I think until we have hard scientific evidence that particular strains elicit different viral tropism or have different viral tropism to different cells or different immune responses, it'll be hard to definitively say. This has been a question that has existed in the influenza field for years and still remains unanswered. So I think it's possible, and it'll take a while to sort that out.
Okay, and one for Dr. Schilling. Are there any specific pre-existing arrhythmias that increase the risk of cardiac complications?
So pre-existing arrhythmias. I mean, again, nothing that we know about in particular in terms of arrhythmias that you come in with the setting of COVID-19. I think, again, the biggest thing we're learning now are what are some of the arrhythmic manifestations that can happen of COVID-19. And I think you have to divide those patients up into those who had no pre-existing reason to have them, and then those who actually had underlying cardiovascular disease, either prior MI, prior non-ischemic myopathy, where absolutely, the systemic stress of the inflammation can trigger. And we see this frequently in many of our cardiomyopathy patients that get infected with other pathogens. This will exacerbate and trigger a number of arrhythmias. Obviously, once you start having a lot of arrhythmias, this makes it sort of a downward spiral, if you will, in the management of these patients, because you have to try to, sometimes back off on some of their IV support. They become more hemodynamically unstable. You try to use agents like amiodarone, which are not benign and also can have negative sequelae in terms of cardiac output. So I think the arrhythmic management can be a tricky piece of this, but as far as what you have pre-existing, it's just if you have conditions that make you already at risk, that this is going to be a larger challenge in your management.
All right, excellent. Thank you so much to both of you for joining us today. Stay tuned. Next week, we're going to continue our talks with another feature on some of the research with COVID-19. So again, thank you, Dr. Schilling. Thank you, Dr. Lavine. And we'll see everyone next week.